Okay, I want to welcome you once again on this tutorial by Geoffrey Mtale. My name is Geoffrey Mtale, and for those who are interested in my qualifications, I just written just down there. I want to welcome you once again, and I want to appreciate you for always watching my tutorials and sharing. I encourage you to subscribe. Don't forget to subscribe on my YouTube channel so that you can be receiving other tutorials immediately they come in. And also I want to appreciate you for always sharing the link to this tutorial so that very many people. So for students out there who are watching, yes, I encourage you to read more about the adrenal gland and then the fine needle aspirate, though I'm going to cover some few things about it, but yeah, you need to exhaustively read through the books. So today we are going to look at the adrenal gland, but fast forward, we really need to understand what is this adrenal gland we are talking about. Actually, where is it found? So the adrenal gland is found on top of the kidney in our body. If we know where our kidneys are, I think, let me get a pointer here. So this is a kidney. When we look at this first slide, this is our kidney, this is the left kidney, and then we have the right kidney here. And then on top of the kidney, we have the adrenal gland. So this is what we call the adrenal gland. This is the adrenal gland, the one I'm actually trying to paint red. This is the adrenal gland on top of the kidney, and even this side, this is the adrenal gland here, which was appearing yellow formerly before I painted it red, but now this is what we call the adrenal gland. So the adrenal gland is very important in human life. Actually, it is important in producing hormones like adrenaline, which are good for proper functioning of the heart, regulation of the heartbeat, and then regulation of blood pressure in the body. So that's the gland we are going to discuss about. So straightforward, let's look at the introduction. And in this we shall begin by saying that the adrenal masses are common finding in abdominal image studies. So when we carry out, or when the radiologists carry out imaging studies, yeah, these masses are very common and they are encountered during imaging. So this can be encountered using the CT scan or the ultrasound scan, and more recently endoscopic ultrasound guidance also has been able to identify them. So fine needle biopsy is very effective in distinguishing primary and mostly benign adrenal nodules from metastatic tumors during staging workups. It can also be used in establishing the diagnosis of some systemic infectious diseases such as disseminated histoplasmosis presenting as bilateral adrenal enlargement. So this should not be mistaken, and when we are carrying out this diagnosis, we have to take keen interest in other different morphological features so that we can be able to make conclusive diagnosis. So the accuracy of adrenal FNA is excellent, with a sensitivity of at least 81% and a specificity approaching 100%. So this is really very good, and this is a very good diagnostic tool that we can really use because of its specificity, which is high, and its sensitivity. So the diagnostic pitfalls include misinterpretations of adrenal cortical tissue as renal clear cell carcinoma or histoplastic carcinoma, and we see that adrenomedulla as a pheochromocytoma or vice versa, and inability to distinguish adrenal critical carcinoma from adenoma. This is very important, but we shall look at this and how to differentiate the adenomas from carcinomas in our subsequent slides, and the subsequent tutorials, actually not in the subsequent 2 slides, but you keep watching and following my YouTube channel, because other tutorials are going to be coming up when we shall be looking at how to distinguish between these two. So let's begin by looking at the lesions of the adrenal gland. Just like in my previous tutorial when we were looking at the FNA of the kidney, we looked at the benign lesions of the kidney, and then we went to the malignant lesions of the kidney, And same way here, we shall also look at both the benign and then we look at the malignant lesions. So for this case, let's start with the benign lesions. And the first type of benign lesion that we are going to look at as of now is what we call the myolipoma. So what is a myolipoma? Myolipomas, these are benign neoplasms of the adrenal gland, or more rarely of the retroperitoneum. So they can be found on the adrenal gland on top of the kidney, or rarely they can also be found in around the peritoneum and various other sites. It is composed of maturing hematopoietic elements and mature adipose tissue, and it occurs unilaterally in older adults, and it presents variably from a small incidentoloma to symptomatic massive tumors, which are approximately 30 centimeters with hemorrhage. So these incidentalomas, just like the name states, when we talk about incidentalomas, these are lesions that are incidentally found during imaging. So they are not the primary the intended, or the primary intention of somebody carrying out the imaging is not actually to identify these lesions, but incidentally they are come across, and that's why we call them incidentalomas. So they can be found and they can appear naturally in older adults, and by variably form a small incidentaloma to a symptomatic massive tumor, which are approximately 30 centimeters, sometimes with hemorrhage. Hemorrhage is a key feature that we shall be encountering in the myolipomas, and it is very important in distinguishing it from other lesions. So aspirates show a mixture of normal fibroid adipose tissue and bone marrow elements in variable proportions. We shall look at these images and then appreciate them. So the identification of megakaryotes is usually the most crucial step leading to correct diagnosis of these lesions, and this has to be taken serious, that when we identify actually the megakaryotes and we look at the clinical history and the site of where the aspirate has been gotten from, and we get realized has come from the adrenal gland, and then we see the megakaryotes, then this should be pointing to diagnosis of a lesion in the adrenal gland, and this is something that we really need to be looking at to help us make good diagnosis. So we need to look at the cytologic features that will help us actually during our examination procedures, and here we look at a condition where we shall have a mixture of mature fat and maturing hematopoietic elements, which shall appear in the slide, and noticeable megakaryotes, just like mentioned on our previous slide. These are very important. So differential diagnosis and problems in diagnosis, this may be confusing. Like for example, it may be hard to distinguish the leoma from the angiomyolipoma, and for cases of lipomatous tumors and the extramedullary hemopoiesis, these could be confusing and they need to be really critically looked at. So looking at images of how the myolipoma will appear on the slide, on our left we have let me get my pointer once again so that we can. So this is our left, and this is a slide labeled A. This is A here, and I've labeled the slide B. So let's look at slide A. We say we have cellular smear showing the trilineage hematopoietic elements with megakaryotes in the center. So when we look at the center, we can really see a megakaryote, which is really appearing in the center here, and this is a key feature in diagnosis of myolipomas. And then we can have other megakaryotes which are not really very big as this, but there are other megakaryotes that can also be actually identified here, though they may not be as big as this one, but all these megakaryotes are really very significant in diagnosis. So we also have hemosiderin-laden macrophages, and the calcifications are common in large lesions, and this really appears in diff quick. So when we critically look at these cells, we can actually see some deposition of hemosiderin. Now, like when we look at the cell here, yeah, there is some deposition of hemosiderin around here, and even this one, they are really very small to see. Actually, even this cell here, we can see some deposition of hemosiderin. So in slide B, we appreciate that we have the adipose tissue, which is frequently mixed with hematopoietic elements and all lymphocytes, and this gives a false impression of hypercellularity, mimicking liposarcoma, which is not actually liposarcoma. So we need to take keen interest so that we can be able to differentiate between a myelopoma and then the liposarcoma. What I can say of now, that in the liposarcoma we shall actually see a lot of cellular atypia, which will be manifested and which will be consistent with the malignant reactions, which may actually not be the case with the myelopoma, which is a benign tumor. So we have another tumor or another neoplasm, and this is what we call the adrenocortical neoplasm. And we see that the adrenocortical adenomas occur approximately in about 5% of adults, and account for approximately 50% of all the incidentalomas. We said previously that incidentalomas, these are tumors or lesions that are encountered incidentally. We don't intend on the initial plan that we are going probably to look for incidentalomas during images, but incidentally we come across them. So as in other endocrine glands, the true adenomas are unilateral and solitary, whereas in hyperplastic adenomatous nodules can be bilateral and multinodular. So the cytomorphology of normal cortex, hyperplastic nodule, and adenoma is indistinguishable, and therefore a diagnosis of benign adrenocortical tissue or nodules or adenoma can only be rendered in conjunction with clinical and radiological colorations. So we cannot only base on the cytological appearance or the morphological appearance of the cells to draw conclusions in cases of the adrenocortical neoplasm, but in conjunction with other auxiliary tests like imaging and then the clinical history of a patient, we can draw a conclusion that actually that is an adrenocortical neoplasm. So the typical smears are at least moderately cellular, with numerous naked, round, and uniform nuclei in a frothy microvascular lipid or granular background. Large cellular clusters with wrapping endothelial cells or transgressive vessels are also present in this case, and the intact cells have either granular or vacuolated cytoplasm with indistinct cell borders. So random nuclear elements, like for example in the endocrine atypia, can be seen, but mitosis and necrosis should be minimal or is minimal in this case. So we don't expect to see a lot of necrosis and a lot of mitotic reactions in this case, but we are not again saying that they are completely excluded. There could be there. So when we look at the cytologic features which can actually help us to distinguish the tumor or to diagnose the tumor, when we look at the slide, what we expect to see, we at least expect to see moderate cellular smears, and then there is a microvascular lipid background. There are numerous naked round nuclei where the nuclei does not actually seem to have the cytoplasm, or we cannot clearly identify the cytoplasmic margin or the cell margin in that case. And we also see the intact cells with indistinct cell borders and granular or vacuolated cytoplasm. and there is lack of necrosis and mitosis, or the mitotic reactions in the background. Differential diagnosis and the problems that may be encountered to differentiate. We may find challenges in differentiating or making a conclusion between the adrenocortical carcinomas and then the renal cell carcinomas and then hepatocytes, as the cells may also mimic the appearance and the cuboidal nature of the hepatocytes in that case. So we have an image, we have images here illustrating to us how the adrenocortical nodule or adenoma will actually appear in the slide. And this is a cellular aspirate with numerous dispersed, relatively uniform bare nuclei in a frothy cytoplasm background. Yes, we need to take these words. Let me get my pointer. So we are saying the aspirate in the first case is, we are saying numerous, dispersed. There is no cohesion in this case. They are fairly dispersed and relatively uniform. So if they are uniform, it means they are barely of the same size. And the nuclei is bare. We can hardly tell where the cytoplasm is, but they appear to be like they don't have the cytoplasm, and they are appearing in a frothy background, a frothy cytoplasmic background. And then we have a frothy cytoplasmic background. So let's get back to image, and this is image A. So this is what we are referring as to the frothy. Even when you look at it, the appearance of the background itself appears frothy. So this background is very important when we are looking and when we are diagnosing the adrenocortical adenomas. And when we look at the nuclei look bare. We can hardly tell where the cytoplasm or the cell margin is. The cell looks to be bare as if it has no cytoplasm. And then when we look at these cells, the cells appear to be uniform. They are relatively uniform in the size, and there is no cohesion. They are properly dispersed, singly dispersed. They are not crowding, but they are dispersed properly and they can be easily seen. And the same thing happens here. We can really see the frothy background, like we can see here. This is not cytoplasm, but we can really appreciate. And at some point we said there is vacuolation in the cytoplasm and the nucleus for some cells. So under higher magnification, if we looked, like for example, we have this cell here, there is some vacuolation here. If you took keen interest to look at it, and even when you look at the cell here, you can see, but under higher magnification, that can be really appreciated. So away from the benign tumors, let's now look at the malignant tumors of the adrenal gland. And the one we shall look at first is what we call the adrenocortical carcinoma. And this is a rare tumor with a bimodal age distribution, peaking at younger than 6 years old and between the ages of 30 and 50 years. In contrast to adenomas, the tumor is usually large. We looked at the adenomas and they were measuring up to 3 centimeters. So this one is a little larger, and this will measure actually in sizes of greater than 5 to 6 centimeters. It is urinato and functional up to about 80%. So Cushing syndrome may be the first clinical presentation, and virilization or feminizing adrenal tumors is likely to be a malignant. So metastases are commonly present at diagnosis and help to prove malignancy. I think when we talk about metastasis, we appreciate that this is a type of cancer. This is a condition or a stage in cancer where it is spreading from its primary tissue or its primary location where it started from and spreading to other parts of the body organs. So that's a condition we call metastasis. So in the cases of metastasis, which are common, and these are common in the malignant tumors, because neoplastic tumors do not metastasize, and it's only malignant tumors which spread from one point to the other. So the aspirate smears from most cases show obvious malignancy, and when we talk about obvious malignancy, we are talking about the cellular changes that are really typical of malignancy, and these will include hypercellular smear with predominant intact single cells in a necrotic background. There would be hyperchromasia. The nuclear membrane won't be intact. You shall see the distribution of the chromatin in the nucleus will also be gross, and many other atypical features which are diagnostic of malignancy, like increase in the cytoplasm nuclear ratio, and other factors that we consider. So the tumor cells exhibit moderate to marked cytologic atypia with diffusely large atypical nuclei, granular to vacuolated cytoplasm, and prominent nuclei in this case. So an increased number of mitosis is also exhibited, especially in atypical mitotic figures, which is a clue to malignancy. And because many histological criteria for malignancy, such as capsular and vesicular invasion, cannot be evaluated by FNA, definitive distinction of a well-differentiated malignant tumor for adenoma can be extremely difficult. So given that in FNA we cannot really demonstrate the capsules, it is very hard to actually conclude. And what we do in this case, it is always important to take a biopsy and maybe do a cell block, and this can really help to differentiate the malignant tumor from the adrenal adenoma, because we realize that in cases of metastasis there is invasion of the nearby tissue, and this cannot actually be seen because when we in cytology we are looking specifically at cells, so we may not be able to demonstrate how far it has spread through different margins. Therefore, and in equivocal cases, the interpretation of atypical adrenocortical neoplasm, this should be considered and the surgical resection be advised so that we can get a biopsy, process it, and then we stain it using the histological stains, preferably H&E, and then we shall be able to identify the features that will be suggestive of metastasis and the other atypical changes that we may be interested in. So cells of the adrenocortical organ, they express inhibin, the melan A, and the carelatin, and this is by immunohistochemistry and a negative for epithelial membrane antigen, which is helpful, and this is very important in distinguishing them from the renal cell carcinomas and the hepatocytes, as well as establishing the diagnosis of metastatic site in this case. So we look at the cytologic features, and the cytologic features that we encounter for this case, we expect to have a hypercellular smear. You remember in the cases of the benign, we had the cases where you had the moderate cellularity, but here we are having a hypercellularity with a necrotic background, which was not the case in the benign. So usually we also interact with dispersed intact cells with granular or vacuolated cytoplasm, eccentrically located nuclei with diffuse nuclear atypia, mitoses, including atypical forms, because mitoses are really typical. These are typical signs of malignancy when we identify them either in a tissue or in a slide. So differential diagnosis, we need to really put in mind, and we should be considering and looking at the possibilities of encountering adrenal carcinoma, renal carcinoma, pheochromocytoma, metastatic and poorly differentiated large cell carcinoma, metastatic melanoma, high-grade pleomorphic sarcomas, and others. So looking at the image, this is how it would appear of the adrenocortical carcinoma, and specifically we look at the tumor cells which usually exhibit diffuse and marked cytologic atypia and polymorphism, and these are key features. So when we look, if we begin with our slide A on our left, we can really appreciate the polymorphism in this slide. We have cells of different sizes. You look at these cells, a little bit bigger, then we have a smaller one here. So this is polymorphism, and then others are oval and others are round or somewhere around. Look away from that. When you look at the chromatin is coarse, it is granular inside. When we look at the chromatin arrangement and chromatin appearance, so all these are signs of malignancy of the cell. Away from that, we look at the nuclear contours, the nuclear membrane contours. They are also very regular. You can look at this one, it is very regular. And other features, when I look at here, I can say nuclear molding also, which is also a sign of malignancy, among other many features which point to malignancy. And these are very important in renal carcinoma, adrenal gland carcinoma diagnosis. So we have another malignant tumor, and this is what we call the pheochromocytoma. So a pheochromocytoma is the primary tumor of the adrenal medulla, and usually causes the proximal hypertension, palpitation, and even cardiac arrhythmia due to release of excessive catecholamines by the tumor cells. So the tumors, what would cause, actually, if I'm talking about this briefly, we understand that the catecholamines are the ones which are responsible for hypertension and then palpitation and then cardiac arrhythmia. This will increase the heartbeat, increase the blood pressure, which will result into that. Actually, in many cases, when a pheochromocytoma is suspected, we don't actually go for FNA immediately, because you may realize that these patients would be having high blood pressures, and given that we are going to draw the needle into their body, and this is traumatizing, a process is traumatizing, sometimes it may require a patient to go under complete anesthesia, and under such conditions we may not actually go for an FNA of the adrenal gland, because we may exacerbate the condition and maybe even lead to death of a patient. So the same tumor can also occur in extra-adrenocytes, commonly in the retroperitoneum, and it is called the paraganglioma. So I was saying that the majority of the patients are diagnosed based on hypertension and the elevated blood and the urine levels of catecholamines and their metabolites and the adrenal or paraspinal muscle. So therefore, a preoperative biopsy such as an FNA is usually unnecessary in just cases, just like I mentioned before. So FNA or pheochromocytoma or the paraganglioma usually yield cellular smears with a blood background like those of many other hypervascular endocrine organs. The smears are composed of predominantly dispersed single cells and small clusters. So the tumor cells exhibit the neuroendocrine cytomorphology, which may be of polygonal to plasmacytoid in shape, and the gland nuclei with the salt to pepper chromatin and cytoplasmic granules on Romanesque based stains. There is marked nuclear polymorphism, anaplasia, and scattered spindled cells, which can be seen, and they are common, but necrosis and mitosis are unusual findings in this case. So demonstration of the neuroendocrine differentiation by immunostain for chromogranin and synoptasin and lack of cytokeratin expression differentiates them from the adrenocortical carcinoma and other neuroendocrine carcinomas. Cytologic features, here we shall appreciate that we shall have cellular smears in a blood background. We shall have dispersed epithelioid plasmacytoid cells and spindle cells. At the same time, we shall have the salt pepper chromatin appearance with ill-defined cytoplasm and red cytoplasmic granules. Still, we shall have bare nuclei, which will appear with binucleation sometimes, and nuclear polymorphism. Differential diagnosis should point at adrenal cortical carcinoma, metastatic neuroendocrine carcinoma, metastatic sarcoma or melanoma with a mixed spindle and epithelioid pattern. So looking at images which demonstrate to us what a pheochromocytoma looks like under the microscope. And so we have two images, A and B. So looking at image A, here we appreciate the cellular blood smear with dispersed single cells, some in small clusters, some have bare nuclei, and there is binucleation, which is very common in a pap stain. I think if I can get a pen and then we point out at some. When we look at this cell, we can appreciate the binucleation, because this is a nucleus on its own, and then this is also a nucleus on its own. So this is a case of binucleation. And then when we look at the chromatin, appearance of the chromatin is coarse. It's not fine. It's a coarse appearance of the chromatin. Actually, we have another case of binucleation here. We can appreciate this cell with the two nuclei, and some cells appearing in small clusters. Actually, yeah, well, like here we can see a cluster, some formation of a small cluster of cells. Even here there's a small cluster of cells appearing, and then we have other cells which are freely dispersed, but in as much as they are dispersed, they have atypical nuclear features that can make us draw conclusions that actually these are malignant cells and they are not normal cells. So on image B, we have tumor cells which have rounded ovonuclei with salty paper chromatin and cytoplasmic granules. This is under deep quick stain, and there is marked polymorphism. This is very important, marked polymorphism. So let's look at these cells and see for sure there is marked polymorphism. When we look at how this cell is appearing, the shape of this one is really not the shape and the size of the cell. So this is really marked polymorphism. The cells are not of the same size and the same shape. This is oval. When we look at these cells, this one tends to be round. And then we talked about the blood background. So this is hemorrhagic background here. This is a blood background, and this is very significant, and this is diagnostic in the cases of pheochromocytoma. So that was a brief discussion about the adrenal FNA. I appreciate you for watching and really commenting and sharing these videos on the YouTube. Thank you, and I encourage you to share more. Thank you for viewing, and thank you for liking, and thank you for subscribing. Let's meet again. Goodbye for now.